Welcome back to our PTAC meeting. Thank you all for joining us. This is the period of our meeting where we invite public commentary. We do not have anyone identified that is actually signed up and on the line. But before we move on, I want to just check one more time with the host to make sure that there isn't someone from the public who would like to make a comment. I'm checking. All right. So there aren't any public commenters, which is fine, which allows us now to move into the committee discussion, incorporating thoughts from today's session, the environmental scan that the CDT team shared with us earlier. We're going to start again, just like the committee's done before on telehealth. We're going to take all this information in, our comments from today at the end of the day now, or at the end of the session, and create a report to the secretary on our point of view on optimizing value-based care related to care coordination for alternative payment models and physician-focused payment models. So there's been and will be a lot of information to sift through. So I'm going to ask the team to share the framework. If you could put the framework up, that would be helpful, that we will use to structure our conversation. There are, we want to make sure that the staff who are following along have the opportunity to hear the committee's point of view and the individual perspectives to make sure that they can incorporate our comments into the ultimate draft secretary letter that we can then react to. So there's a couple of things I think we'll just walk through the list, and I would open it up for committee members to respond. And again, if you don't respond here but have a point of view after the meeting, we'll clearly work to incorporate your thinking before we finalize the report. So promising approaches for optimizing the use of care coordination in value-based care to improve quality and reduce costs. This is, clearly the thrust of what we were trying to effectuate today. I have some thoughts, but it'd be nice to hear from the committee on what were some of the key components you heard, functions, activities that we should incorporate in the letter. You see the other sub-bullet here, which is the extent to which promising approaches are likely to vary based on context, specialty, et cetera. Why don't we start with that first section and open it up to the committee if there's any additional comments people want to make. All right. I know there's some.
Sorry, I'm trying to raise my hand. I wasn't working very well.
I know. It's okay, Paul. Technology, hey.
My God.
Get there. No, but go ahead.
Well, in terms of the, one of the things I heard, I think both with the subject matter expert panel that came through and as well with the prior submitters, is around this, the function of the care coordinator. And it could be, there's a lot of discussion around, who is the, descriptions of what the care coordinator, who that should be. I did hear quite a bit around the benefit of that coordinator having some relationship with the patient or have some familiarity with the patient being particularly helpful. But even in some of the other comments that were made by some of the past submitters, including from the Susan from the ED model around, the critical importance of that role in care coordination.
Thanks, Paul. Any other comments? Bruce?
Bruce, you're on mute, I think.
Every now and then somebody will make a remark that kind of sticks in your head. I think it was Dr. Jane who said, we entrust a function that's most in need by patients with complex illnesses to strangers. This is, Paul was just alluding to this. That's the way he said it. That's why it stuck in my head. Then he went on to say, I believe that very often the people who have that trust are not only strangers, but they're often not very well trained and often lowly compensated. And the last panel, they talked about the training, but they didn't address the role of having a personal relationship with the patient. And I guess I wondered if that's, unless you interpret what they said about primary care having a key function in care coordination, the presumption being that primary care doctor would have a relationship with the patient. So I was just trying to put all those things together and wondered if there's a point there to be made that we might want to put into our report, or at least test with some other people, including committee members.
I would like to follow on from what Bruce said. So working directly in this space in so many different directions, that trusting relationship is so key. And I'm very sad I lost signal because I wanted to ask the panel about what they've learned about different disciplines or roles and how they intersect. So the emergence of community health workers, the emergence of people with lived experience, especially in the behavioral health and substance use disorder space, as being really key with being able to build trust and understanding, and also related to equity, people from the culture being the translator and navigator for the culture, I think is a really important emerging theme. I loved also what Sachin said about the longitudinal nature of that trust. So I heard another theme about the disruption from episodic sort of helicoptering in of care management and then it leaving again. And that if we want to see long-term change, that longitudinal relationship and that trust is really key. And I see that in practice on the ground. And I think that's an area that is really promising for additional research.
You know, to just add on to Lauren and Bruce, when you look at it in terms of, you know, who is the best person to be the care coordinator? And the challenge in today's world is it's so complex because so many of the patients have such complex needs. Is it best delivered from the primary care office? Is it best delivered from the health plan? Is it best delivered from the ACO? You know, is it best delivered from the specialist who's delivering the majority of the care at the time? It's almost in the old days, you've seen one health plan, you've seen one health plan. Well, now you've seen one care coordinator, you've seen one, and obviously it almost screams that the level of training definitely needs to be escalated. And the flip side is, how do we compensate for that? Which I think came through loud and clear. How do you provide the resources so we get the right person providing the right care coordination in the right setting?
Mm-hmm.
Jay, I want to echo your comments. I think what struck me is we talk often about care models and then how a payment model may incent that care model. And what we heard a lot today is exactly what you described, in that there are areas of excellence of multiple care models that exist. And yet we still don't, it sounds like, know what, although we described a number of best practices, but it's in its infancy, although we've been at this now for decades or more. And so to create a payment model that incents an undifferentiated care model, this is where it feels like we're in the middle of this conundrum.
Yeah, I appreciate and agree with all those comments, especially Lauren's and Bruce's. I was struck by something else Sachin said, which was that for surgeons or procedurally focused care, they were successfully able to change the conversation from managing the procedure to managing the patient journey, including pre and post care. And for primary care, they're paid to manage a panel, not paid to manage a visit. And that's a really fundamental concept switch that links to the domains and the functions that we've decided are more important, which is are more important than the medical care. You know, optimizing the care for the encounter that only drives 10% of cost is kind of foolhardy. It's linking the journey to the wider context, the patient's community, and social determinant needs that's going to really change the outcome and care continuum. So that just strikes me that all the effort around building care coordination on a fee-for-service menu with codes keeps it focused on the visit, on the encounter, on a reductionistic, I do a bunch of stuff and get to submit a bill. And we really have to move this conversation to value-based care and change that paradigm, or we won't probably ever be able to move past the innovators into scalability.
Going back to Jay's comment, Jay really highlighted a really significant challenge, which is there's so many different places that care coordinators could reside, and where does it make the most sense? And it's clearly not going to be one size fits all. If you think about the social determinants, a lot of the insights that need to be delivered to the patients come from the community. So you could argue effective care coordinators are really the ones that are embedded in the community and know some of the, know the assets firsthand and how to access them. I think there needs to be a way to tether the care coordinator community to the care team. And that doesn't mean they have to be employed by the care team, but they need to be connected to the care team, and it should be fluid based on the patient needs. Within one practice, you can imagine some care coordinators may emanate from the practice, some might emanate from the community, some might emanate from the plan, and we can't let the level of complexity avoid us moving forward with the value of care coordination, because I will say firsthand, when you see it and it exists, the impact is tremendous on driving outcomes. The other comment I will make is that we talk about payment, but I think payment and sustainability, I should say durability, are two important points. You can't say I'm going to pay for your care coordinator for the next 24 months and then it's a black box. Practices are not going to devote the resources to building these programs if they think it's going to be the flavor of the day and then funding is going to be pulled. And again, I'm not being critical of past practices, but this is a problem that people need to solve. And if in fact we're going to go down the road of care coordination and really getting deep and supporting it full and wholeheartedly, we have to be committed to the journey, which means some of the things we'll get and have happen won't be correct and we'll have to pivot, but that should be, that should not be a reason for us to abandon it. And I would say that it's sustainability, which is absolutely critical if we're going to go ahead and start paying for these services long term.
I also think there's some key practices. I didn't want to interrupt our SME panel and didn't get to call those out. I actually, in hearing them speak, realized over the last 20 years, I've actually worked with several of them in what they were developing. So I thought it might be helpful to call out some of those core component practices I've seen them do that they referred to that I think start to solve for some of the challenges we're bringing up. So in Vermont, I worked with the state of Vermont when they were doing their SIM model and designing what they were going to do across the state. And they adopted some of the practices from the complex care model I developed in Trinity, which included a principle of the intervention was to identify the cross-continuum team regardless of setting. So that included identifying not only primary care, specialty care, payer care management, but also the faith community and the trusted neighborhood relationship. So that's a principle. And then they hold a shared case conference of all of those people to develop an integrated story of the patient and a shared plan of care. And they identify who has the strongest trust relationship to carry the main contact with the patient. And they actually built into their ACO payment for development of that shared plan of care. In CareMore's model, they do something similar with how they have an interdisciplinary shared team that develops that shared plan of care. And then they follow the patient longitudinally. So they have a clinic, but they also round in the hospital if their patient is there, or they go to the home. So it's longitudinal and cross-continuum. And then with Catherine from Remedy with BPCI, the other component was they have a structure to create a community of practice amongst the care coordinators so that best practices can be shared and accelerated and translated into pathways for standardization and quality improvement around how complexity is dealt with.
Just add to some of these comments. I think I agree with a lot of them. And what I'm kind of turning over in my head is this idea. I love this idea of moving from kind of a smaller unit of a case to a journey, of a patient to a panel to a journey. I'm trying to square that with comments that I've heard today from committee members and SMEs about kind of like how close any team member is to like the locus of control over that, right? So the letters BPCI have been mentioned a few times, and whatever we think about that, it very targets the energy, right, between the hospital and the post-acute setting. Imagine it's pretty hard for a primary care doctor who may or may not know, based on the data feeds that patient's admitted, and or may not know what the plans are, to reach in kind of distally from where they are to address that point. And so I just think about, as we expand to that journey, though, we do need nodes along the way, right? And some insight about who is as close as possible and appropriate to kind of intervene in a way that achieves quality and cost. And I think we heard a lot of perspectives on it. It's still an open question in my mind, and I think worth consideration going forward.
Bruce, you have your hand up?
Not on purpose.
Okay, very good.
Josh made a really interesting point that got some neurons firing for me, and you could see the beginning development essentially of a standard model of interconnected care coordination models. There's one from acute to post-acute, then you manage the interface before that goes to population primary care-based care coordination, and then selected patients that wind up with a disease or high-risk condition interface, and you manage the interface and the handoff between a disease-focused care management, care coordination panel. Suddenly you start to get, two or three or four defined models with defined interfaces that can be managed and handed off. Suddenly you can wrap care coordination kind of systematically around most patients that need it with the appropriate model and inputs at the time they need that.
Thanks, Lee. Amy, maybe you can drop the slide. I think all of the committee members printed out these bullet points in advance. That way we can see each other. It's a little easier. Any other comments before we move to some of the challenges? And again, we sort of touched on some of them already, but just to make sure we cover the waterfront. There are 5 challenges here listed. The first one is related to the beneficiary and the caregiver needs. I would say, it's interesting. We all talk about how much money is spent by CMS and CMMI for providing care. I think the unsung hero here is the dollars that get poured out from families when they can least afford it on providing care and care coordination that is not very well known. It's not very well quantified, but it is material, and it's only going up. So I think that that's a huge challenge, to really understand the economic consequences and how difficult it is to navigate the care coordination, meaning to get to the place, like you said, Bruce, earlier with your family member, to get to the point where you're actually connected to a care coordinator. You almost need a navigator just for that. So I'll stop there and turn it over to other folks on the committee for their input.
I have two more points to raise, and one, Josh, your comments made me want to speak to this. And that we heard this from our panelists around data and data governance, and who in that care journey has access to information and data, what's the level of validity of that data, privacy issues, and that really, we've talked about this before in other settings, including our telehealth conversation, but that keeps coming up as a real challenge in order for us to not only communicate with patients, but in order to really understand their story without having that verbal interaction, but being able to use it digitally or in written form. That's one comment. And then my other comment is around, this has really got me thinking about, we're thinking about payment models to incent all of the units who might ultimately impact or help manufacture a good outcome related to healthcare. But what we didn't actually surface much today were what are the incentives for patients that were successful in these programs to participate. There's not just financial incentives, right? There's obviously other incentives that exist for engagement, but it did get me thinking about, might there be a model even for financial incentives, much like we saw, in the what sparked national conversation around, payments related to COVID. I know those weren't specifically for healthcare needs and were more for the economic crisis, but it feels like that's something that we haven't focused on. It could be an opportunity.
And Lauren, you had your hand up.
So just to follow on what you said, Jeff, I think it's really important to highlight the cost to families and caregivers. So when you look at models like BPCI and many others, there's an incentive to reduce the cost of post-acute care. And that cost then gets translated to the family of the patient. So it's really, we heard a lot of themes about the importance of patient and family defined value. So paying attention to the cost, the access, and then on the other side of the equation, we didn't talk a lot about care coordination with behavioral health and substance use disorder. And in that space, it's often a place where the family is not integrated in care coordination, partially because of policy and regulation and also perceptions about HIPAA. So there's an opportunity to enhance that family unit, but really pay attention broadly to the cost to that unit and what support is needed to sustain it.
Thank you, Lauren. Maybe I'll just read the rest of the challenges because we are touching on them as we move along, but there are the health system challenges. There are challenges that are related to the providers, including incorporating community health workers. We've talked a little bit about that. Infrastructure challenges. Jen was talking about data, and I think that is just, like in all of the care delivery components, that's a huge issue. And interoperability or lack thereof has been a longstanding challenge. And health equity challenges, which we heard about a little bit today. I know Kavita has her hand up.
Hey guys, thanks, Jeff. Lauren, when you talked about behavioral health, it just kind of also reminded me, it feels like, and I think those of you who do this kind of in the ED or in primary care can commiserate, even if we were given, even if HIPAA, even if all these policy and regulatory barriers were relaxed, combination of not having an adequate workforce, which has been touched on, but then also it's very hard to kind of get through, it's very hard to coordinate behavioral health care due to the very, I don't want to say unique nature of behavioral health because it makes it sound like it's separate, but it is separate. And there's just a very, I hate to say it, most of what I need is done with a psychologist, not a psychiatrist. And so there's a very different approach to kind of therapy and their notes and how they understand kind of the medical conditions. And so, Jeff, it was reminding me, like, you know, when you're an at-risk, probably what you led back in the day, like if you're an at-risk multi-specialty group provider, you're motivated to like figure out how to get people to work together, talk to each other. And so, yes, the payment helps and the policies need to change, but there's something about like both the workforce and then just the, PTAC can't fix the woes of medical education and, you know, the problems with that. But it does seem like as we do these APMs, like these leaders that come to us and these submitters, when you were talking about hospital at home, like, and when Liz referred to kind of, you know, thinking about something that's, you know, where everybody has to do it, so to speak, you aren't going to get there if we can't really kind of fundamentally augment like the bread and butter APMs with some way to give people like almost like a toolbox, kind of like ACOs of like, and here's how you do it for dummies. And that, again, that's not PTAC's job, but it's an interesting thought that like if these submitters or people who are advanced in their thinking, they've got that toolkit, you know, they can't submit it in their 20 pages, but they've got that toolkit. Can that become like a place and a place to build off of? But I can't underscore behavioral health enough. And I'll tell you that even when we all try and do things and work together, I feel like we're speaking different languages. And it results in, you know, I can't even read their notes because they're so long and I don't have time and, you know, I need the punchline. And so you really have to have a relationship with somebody, and that takes a different culture and mindset. Anyway, just Lauren, you just really kind of brought it home for me.
Thanks, Kavita. And almost, you know, I mean, just for the kind of folks that really need care coordination, the folks with multiple disease states and complicated disease histories and lots of comorbidities, they're the ones that really need that behavioral health support, and their family need that connection. You know, Kavita, many sophisticated practices embed behavioral health to some degree in the primary care practice, and that has shown to be hugely successful. I'm not seeing a lot of catastrophes when that's done. Actually, it's just the opposite. It's very impactful and very effective. But again, it's not, there's, you know, limited supply and limited infrastructure to make that happen. But I think it's important to key off of the fact that if there's a playbook where, you know, people can learn how to do it, you know, how do you do it if you're not in a multi-specialty group practice that's owned by an integrated delivery system? How do you do it if you're a 1 and 2, you know, individual primary care practice? What about the specialists who often get burdened with these behavioral health challenges and really have no ability, without completely blowing up their practice, to get the patients connected to behavioral health? I mean, it's very arduous, and we need to simplify it. So there's one, the need and recognition that behavioral health is a critical component that really will impact care coordination. When you think about all the specialties where care coordination needs to be embedded, behavioral health probably is at the top of the list. And then if you think about that, then what are the multiple permutations on how to deliver behavioral health services to the community of practitioners and patients in a rural setting, in an urban setting, and get that out there so we don't have to have multiple chemistry experiments like you were saying, Kavita.
At the risk of oversimplifying it, I like that idea of playbook, and I wonder if the way that I'm hearing in some ways, Jeff, from what you're sharing is there's multiple versions of it, there's multiple playbooks. I think if you have an integrated system that has a multi-group practice, that has a large enough footprint that spans the gamut where you can actually zoom into what Lee was describing, kind of primary to hospital to post-acute and back, I think that looks a certain way. Many of the comments I heard today feel like aspiration, you could get there. I think it's much less interdependent than on the other side, where you have 1 or 2, 3, 5 primary care doctors who need those data feeds, who need the infrastructure, or those subspecialists that have analogous issues. Without really infrastructure, I think barriers being overcome on that side. I think it's hard to take those really important values that might work in that more integrated setting and say, we can use it here too, or we can begin to get there. Is very unlikely. So I'm just trying to braid together some of what I'm hearing, and maybe there's a distinction there about what the near-term targets can be, and within that, what PFPMs can reasonably do.
Well, I agree with you, Josh, but I would challenge the folks who are listening in. We got over 170 people from around the country listening to our discussion today. I know that there are communities that have solved this problem across the entire clinical spectrum, from integrated delivery systems to very small practices, as you just described. And we need to make sure that their voices are heard and that we get, though we collectively, I mean, the people, not just the PTAC, but the people who are trying to establish and create these models and then pay for them, that CMS and CMMI hear from that stakeholder community and understand how they did it, and then incorporate those elements into a model and into a playbook. I think we talked about stakeholder technical assistance, and I know that that's not something that the PTAC is set up to do, but we certainly can raise that issue and encourage CMS and CMMI to pursue it. So thanks for that point, Josh.
I'm going to make a adjacent point, but one that I still think would help ultimately the stakeholder community in the idea of a toolkit. And Lauren, you discussed this earlier, and that's that we wait for randomized controlled trials to be published in the peer review literature to justify big moves, because this is high stakes. We're looking at large populations of patients, big dollars potentially, and so there's often a reluctance to make decisions without that really hard evidence. That said, I think, Jeff, to your point, there is excellence out there across the country that we may hear about in various pockets, but it's not escalated and made transparent or celebrated in spaces that are outside of traditional research. So I think really there's an opportunity to partner these care model clinical operators where excellence is happening with our health services researchers and our implementation scientists, and really link them together because there are excellent outcomes that are out there that have not been described. And I think that's really where there's a gap.
I just want to follow on what Jen said. I completely agree. And when you think about it from an equity perspective or social determinants of health, I spend a lot of time in the most extreme spaces. They're also often the most under-resourced from a financial perspective. So it can be very difficult, but it also can be a land of tremendous creativity and creative solutions. And I think there's a great opportunity there to highlight some of the lessons from working with outliers that can really translate to broader systems change. There isn't competition for that market often. And so the people working in that space are often collaborating in new and different ways. And in working individually with care coordination for patients, simultaneously working on what are the system changes that need to be followed, whether it's build of the ecosystem and services or process improvements between systems so that we stop creating more complexity and more people in this bucket. And those lessons I think are very valuable to translate in the care coordination space, because they start to not only improve outcomes for the patient and family, but actually change the root cause in the system. But a lot of them are not in the literature because of the lack of research support.
Yeah.
And just to add on again to those comments, and I think to Jen's point, and was brought up by the PCDC, if you look at care management, I mean, it's been hard to prove in terms of sort of cost effective and the cost point. And several of the SMEs talked about it, and and they brought up how the idea of just looking at ED and hospitalization as the outcome is really limiting. And so to the points being made that there are many creative, just to emphasize, there are a lot of creative models and to rely on sort of either a randomized trial or sort of this pre-post kind of analysis with all sorts of, it may not be the answer as opposed to sort of the real world experience of what's working.
This kind of reminds me of an analysis I did a number of years ago, actually about the BPCI program, where because of the DRG payment, most of the attention looks at what happens after the hospital, where they go, how much care they use, and we were able to look at data in the hospital and see, are the hospitals reducing costs, and what are they doing to quality, and that gave just a total different lens to the data. It's a very specific example, I think, but speaks to the broader point that without that, it's going to be hard, because our eyes will be drawn to where you can count the dollars or count the quality and not to other places. And I think that's to our detriment. So I think, Jen's comments and others about kind of bringing attention to it and kind of finding ways for researchers and people who study data to work with communities of excellence, I think is really critical.
I wanted to talk about shared decision-making. It was brought up by Sandra in the SME panel. And Robin also talked about engagement, the patient engagement. And my feeling about shared decision-making, it's easy if you say it fast, but it's very, very complicated. But when it's done and it's done well, it's incredibly impactful. There's been lots of studies that have showed of all of the things that bend the cost curve, shared decision-making is the number one or one of the primary ones that actually bends the cost curve. And patients have the information they need. They not only does their mental health improve, but so does their clinical status, believe it or not. Even when they looked at patients with end-stage cancers, shared decision-making actually improved the overall health status of those patients. And if you think about, if you're a patient and you want to get the information, we talked about the care coordination. Those are lots of different points. If you think about points of providing potential insights that help the patient navigate their care. And so the care coordinator has a lot to do with that, but it's also the clinical community that has to weigh in, the care team, if you will. It has to weigh in and make sure that the patient's informed. In my experience, not everybody's good at care coordination. Not everybody is good at having those shared decision-making conversations with patients. It's not like a gene for shared decision-making. It has to be a learned skill. And if you look across at folks who've led large practices or had exposures to lots of different clinicians in their day, some you'll find that are really, really good at having those very critical, crucial conversations with patients to help them and their families make the right care decisions, which sometimes, we talked a little bit about it, is not some aggressive procedure, but actually going down more of a palliative care road that is more appropriate, and certainly, I think, from a mental and clinical outcome standpoint, is probably more cost effective. The dollars will follow. My belief is you can't set it up for dollars. You have to set it up for what's doing the right thing, and then I think the dollars will follow. So I wanted to make sure that we did not lose sight of shared decision making. It is critically important.
Just a quick comment on that. I'd say that you're right. Easy when you say it fast, and even faster when you say SDM. Just acronize it. But I do think one of the key things behind that, for me at least, is that, to your point, I think, Jeff, is that behind that decision, it's agnostic to the dollars. It's saying, let's do the right thing. Let's have that conversation. If it leads to this care or that care or neither, that's good. So I think as I step back and see kind of the communities that have come to discuss care coordination and the comments we heard from SMEs today about we mean different things, right? It's not a semantic exercise. I think it is because some people come in the back of their mind, it is a dollars thing. So behind a decision, we're trying to see solve that issue. Other people are thinking from how do I get evidence-based guideline concordant care, which oftentimes, particularly with an equity lens, may mean more care, right? And if we adopt a view that says, let's do the right thing for people and their caregivers, let the rest shake out, I think it's yet a different and healthy, but a different view. And so I do think some coming to the middle on that issue is helpful. It plays out in definitions, but probably other areas too.
Thanks, Josh. Any other comments? I don't want to. We've got a few more minutes. I think one of the other comments I wanted to make was about disruption. I find myself, if I don't purposely monitor my thinking. I go down the traditional health system, healthcare, hospital, clinic, that kind of care delivery. But I'm here to tell you, you just have to open up the journal, any day of the week, and you'll see all of these new companies that are coming out into the marketplace that are causing and creating a significant amount of disruption and changing the paradigms on how patients and how family members get access to care. And a lot of it is good. Most of it is good. And certainly the healthcare system, I think, needs this injection of disruption to get us to move forward. But I do think we need to also understand that there are ramifications of these disruptive companies as they enter the primary care space, Medicare Advantage, all of the venture capital dollars that are going into it, and there is a boatload. We need to understand it, try and look over the next mountain and see what the ramifications are for all of this consolidation and all of these new young, energetic companies that are introducing the marketplace and disrupting the delivery system. And again, it's a little off point for care coordination, but a lot of what makes these companies successful is their ability to get in there and connect directly with the patient and their family and coordinate their care in some way, albeit primary care or otherwise. So I just think it's something that we should just call out and make sure that CMS and CMMI have the bandwidth and the attention to pay attention to these new companies and their approaches to the marketplace, because I don't think they're going away and they're going to become more pervasive, not less. And we need to make sure that the payment models and the clinical models support them.
So, Jeff, you must have been reading my mind, because this week you had a Medical One acquiring Iora Health, which in the Medicare Advantage space is basically builds their model around care coordination. And there's a lot more publicly traded companies that are growing and growing, and their primary focus, for obvious reasons, are commercial products. But we do need to understand what their downstream effect will be on Medicare space and Medicaid. And it may behoove us at some point in time to do a miniature version of what we did today with a select group of those companies, so that we could get a better feel and understanding of how they're looking at the future of care coordination, because quite a few of them are care coordination companies.
You're right, Jay, and look, I'm in complete alignment, which is why I brought it up. And you can see, you don't have to think too deeply. You can see positive benefits. That's an oxymoron, but you can see benefits. But you can also see downstream ramifications that might be harmful. Cherry picking isn't the right word, but if certain payer mixes get shifted into certain models and hospital systems are left holding in caring for a disproportionate number of more challenging patients where the economics are not as favorable, you can imagine there's a lot of downstream consequences. And that's why I think we need to get ahead of it now, so we can be thoughtful and not have to get behind the curve. I think that's your point, Jay. If we can, bring these people in and start developing a dialogue.
Because it cuts to the equity issue. Sure.
Yeah,
it really does.
And in a very deeply, it cuts very deeply. Lauren, you were going to say something?
I was just going to follow on to what you said. So I think there's a couple of disruptive but valuable ideas that are coming forward from a lot of those companies. And one is that screening and addressing social determinants of health isn't an optional activity. It should be required, just like a medical head to toe comprehensive assessment. It is part of holistic assessment and care of a person. So that is a principle is key. And then the other principle I'm seeing many of them operate on is high utilization, whether it's the emergency room or inpatient, is a metric that indicates systems failure. There isn't a reason someone should access the emergency room 100 times in a year. There is no clinical reason for that. There is no clinical reason for utilization beyond a certain threshold. But we don't hold accountability for that in the system now. And taking that in deeply the people who are doing that are starting to change how they approach what they're delivering, and it makes it less vulnerable to disruption from a siloed approach in cherry picking certain parts of the population.
I think just for the purposes of our colleagues who are listening in and trying to track our comments, if you would indulge me, I'll just read through the rest of the framework to make sure that there might be other comments people are thinking about that might not have been raised yet. And this is around the role of APMs in physician-focused payment models. The two bullets under that are how can APMs and PFPMs help to incentivize the optimal use of care coordination. Clearly, some of our model submitters who talked today, they believe and have embedded those concepts into their models. I'll just read through the questions and then we can open it up. What types of payment models are likely to incentivize care coordination, including specific care coordination functions? So that's under the role of APMs and PFPMs. Any comments from the team that haven't already been made that people want to make in that section before we move on?
I would just say, as said earlier, that really focusing from the encounter to the journey is going to then incentivize the importance of care coordination in whatever model.
All right. Lauren, are you still on? You might have lost Lauren.
Yeah. I was just going to add, I agree with Paul, but it's almost maybe it's too simplistic, and I have a simple brain. But essentially there shouldn't be an APM that doesn't include care coordination in the domains that are important in that venue. I mean, it's table stakes.
Well, certainly Lee, the secretary thought so. That's why it was one of the criteria, right? And
yeah, right.
We're all in on that for sure. Thanks.
You bet.
I think I'm back, Jeff. I think what was really interesting this morning, and also I heard it as a theme from our presenters, is the concept of can we really create integrated care coordination across payers? So payer agnostic, that it's a principle of what we deliver from the healthcare system. I think that's where there's real promise for significant change.
Well, it's good that you mentioned that, Lauren, because we had a conversation with Liz Fowler in the morning prior to the public session, and one of the things that we talked about was a multi-payer strategy, given the challenges that CMS and CMMI have as it relates to model development. That commercial payers are often better positioned to test in smaller communities, given CMS and CMMI's reach. And I think that you brought it up, and I'll just say it here for the purposes of our report. I do think a multi-payer strategy and coordination with the commercial payers is going to be critically important because they offer optionality that is challenging CMS and CMMI. When you talk about the timeline of model development, it's very long, and there's reasons for it. And I'm not being critical, but it takes a long time to get a model from concept to deployment. 18 months to 24 months has historically been the case. And I know they're working to speed that up, but nonetheless, that is a challenge. And I think the commercial payers can add a lot of value here. And they have a lot of insights, and they already are working in this space, but it'd be great if more of that energy could be coordinated. Thank you.
And I just wanted to add on, I was just thinking about what Lee said about table stakes, which I think is right. And I think that's, as we reviewed so many of these models, we felt that, a certain number of the models really, although they commented on care coordination, they really didn't sort of do a deep dive and really give us enough to believe that there was, that it would really be well coordinated. Others were better. But even in the ones that sort of met, looking at the PCDC and some of the information that was in there, it seemed that the majority were focused on specific populations. And I think we tend to do that. We tend to think around whether it's a clinical condition or a specific piece of the journey I'll go back to, and really going from that sort of, whether it's a clinical condition or a clinical type of population, to that broader. I think it continues to be extremely challenging. I think we've learned a lot today to help flesh that out further, but still a lot of challenges around that.
And I just highlight one point within that, which is kind of going back to that piece of the journey. If we can think of care phases, not as a exact proxy for it, but kind of steps in that journey. When I think about the models that have existed, again, there are some that are focused on hospital to post-acute, some that are focused on primary care exclusively, some that are thinking about populations and types of providers, so to speak. I'm actually really curious what other people think, but when I look at the landscape, what I don't see as much about is that node. If I can take the analogy of hospital to post-acute, that node between primary to other specialty care in that referral process out and back in, right? Which is one I think we would all agree has some opportunities for greater equity or quality or maybe utilization changes. And so, and I just want to kind of say that as one specific area within the context of covering the journey. That seems to be an area we have fewer pieces of evidence.
Yeah, I agree.
Let me, I just have a few more, 5 more bullets that I want to make sure at least we raise them. We talked about measurement, certainly in both the subject matter expert and the proposed submitter panels today. But what are the best ways to measure the quality and effectiveness of care coordination? And I think that maybe we could spend a minute on that if people have thoughts about that. I think it would be important to get them on record.
Well, I really like the idea of the patient or the family, weighing in on if they feel their care is being coordinated. As I said, I know I keep bringing up the ROI is often focused on the ED and the hospitalization. And I mean, that just falls way short of what I think we really want to look at. And somehow that patient, some patient-reported outcome that really speaks to that, I think would be really helpful.
Especially in light of, like, so many of the studies have focused on costs and the fact that, there are cost savings, being able to point to better measures of patient satisfaction, or I can think of things like the collaborate measure, which is asked of the patient or the family, could be really great, also improving its value.
Yeah, thanks, Carrie. I liked what Lee said this morning about outcomes to avoid versus outcomes to achieve. That stuck with me, and I think I wholeheartedly am on board with that principle that we need to move away from the avoidance and move towards the achieving outcomes. Bruce, you had a comment?
Yeah, I was going to follow up on what Paul said, I guess. I go back to my family situation that I reported on earlier. We hired a navigator. The navigator is not a care coordinator. In fact, I think it was Lauren that said navigators are transitional. But the navigator did the needs assessment and got the resources in place for us to look after my mother-in-law. And in 18 years, she had one brief hospital admission for a TIA. I am totally convinced that if we were left to our own devices, we would have spent thousands of Medicare dollars on her. Going from specialty, she had multiple chronic conditions. She might have had surgery that we decided not to go on. And so many of the stories that you hear about the people like her being passed from specialist to specialist, incurring a lot of expenses and not necessarily much quality of life. The problem is measuring those benefits is really difficult. Maybe if we were in a 1,000-person clinical trial with, some people getting traditional care and some people getting coordinated care, you could find the metrics. But I guess my point is to make sure that our base is broad enough that when we start to talk about what families can do for aging relatives or others who with multiple chronic conditions. There's a lot that we could do and did, but the problem is, of course, we can't measure how many hospitalizations we avoided or how many trips to the emergency room we avoided. I'm convinced that we avoided a lot, but I just don't know quite how to measure it.
Thanks, Bruce. Other comments on measurement before we move to the next question?
I was just going to add that emerging interest in including measures of equity. So in addition to disaggregating the data and outcomes by race, ethnicity, and other factors, looking at impact on equitable issues like housing, food security, some of the social determinants, and access to care is just emerging as an area of real interest and continuing to round out the return on investment value case.
The comment I would make is what one of our SMEs highlighted, and that it appears in this space, and I think it was Sachin that said this, it's beyond those traditional outcome measures that you all have noted. It's going to be about process measures and sub-process measures. And again, back to the data and how easy is it to access. But it may be not proof that you made a phone call, which is the example one of our SMEs gave, that just because you made a lot of phone calls doesn't mean there is an impact on outcomes. But maybe having a forced conversation or having a certain type of group involved in care, let's say, from a community health perspective, those are the kind of measures that we haven't previously tracked in terms of engagement that may ultimately be important to outcomes. And then I want to second this comment about PRHO's patient-reported health outcomes and how nascent the data is in that space, but yet how important we think it is. And there have been some medical specialties, including some who've come before this panel that have leveraged PRHOs and showed their impact. So I think that's an important place for us to look to try to see if we're providing high value care, especially in these areas where cost avoidance is nearly impossible to calculate. Yeah,
I appreciate those comments and agree. I would pick up a thread that someone said that the ambulatory CAPS survey is tired, not measuring the right stuff, and at this point, it's an activity in an industry. It's not necessarily useful information, for what happened 14 months ago. By the time you get the results, so I also heard strains about all the challenges, metrics that it feels like, and again, Dr. Weiler probably can resonate with this. The metrics are so methodologically precise, but so difficult in the real world to implement that we're trying to be too smart, and sometimes we're letting the perfect get in the way of the very good. The average medical group leader, without hiring data architects and a team of 6 informaticists, you can't build the data systems to collect the information. So maybe it is process measurements and a bundle measure, like we have bundle diabetes measures, a bundle of combination of some semi-outcome and some process measures that capture more of the heart of coordination than anything does now.
Jeff, if you're reading Jay's mind, I think Terry may be reading mine. I was thinking the word CAPS as he said it out loud. But no, but I do really just want to underscore that point about drilling down and not. And I think there are many reasons for it. But one, as you think about precision, is that even if you could resource it and get those measures, the ability to tie that back to any clinician, the reliability of that and the validity of it is really hard. And actually you see that with the CAPS, right? Where you say, is that reliable in any way? We got it. We got what we wanted, and we don't have what we want. And so I think having some range there about what the measure should be, I think is important.
This is a great discussion. Let me just cover the last 3 here. We talked about research. Is there other additional information that is needed around this care coordination issue, including research questions? I think, Jen, you brought up some research, needing research around this. Any other comments on that before we move to the next segment? Yeah. Carrie.
I was just gonna add, like, I've just been thinking about the different setting issue that it's possible for care coordinators to be located out of lots of different settings. And I don't think we have good research on if there's a way to coordinate across those settings too, like beyond the patients being discharged from the hospital. Should that still be in primary care? And I'm just thinking of research like comparing the care coordinators just being out of a primary care setting where you hope there's a longitudinal relationship compared to a transition manager at the hospital or something like that, in terms of research too. Because it seems to me that it may be that just having the care coordination out of the primary care could achieve those other things, but right now they're not either like looped in or incentivized to do that.
Right. Thanks, Carrie. Two last points here before we wrap up. One is insights from all of us or the committee on review of care coordination components for future PFPM proposals. Is there anything that jumps out that we would like to see embedded in stakeholder proposals on the go forward based on care coordination?
Just reemphasize the point that I made a little earlier, which is that primary to other ambulatory care, that transition. I think ostensibly it's covered under more quote global models like ACOs and others, but I think having some precision around that could be good.
I was just going to add, kind of building on my prior comment too, that if these are specialty models, is there a plan in place also to communicate back to primary care and communicate with primary care?
You know, the other one, Jeff,
go ahead.
It has to incorporate behavioral health. It just does.
Yeah.
Regardless of what specialty it comes from or primary care.
Agreed.
I would add to all of that just this concept of not robust and rigorous in terms of a research, but just operationally, clinically robust assessment of patients' needs linking to community resources. I'm not so sure I'm totally bought off that an 18-page formal care plan is what makes a difference, but understanding that to your patient, their goal is to walk to the driveway and get the mail and back without having to stop to breathe. That type of knowledge of the patient's concrete needs and desires, as opposed to you think it's about they want to make their echo appointments and that sort of thing, makes a huge difference. And so I'd like to see that type of activity more incorporated into the plans.
Yeah. In the patient's words, Terry, right?
Absolutely.
Right.
I'd like to comment on a charge that Dr. Nedza gave to the community, and that's around more interspecialty collaboration when thinking about these models. I think there's an opportunity not only to do interdisciplinary care coordination, which we focused on a lot, but I do think with the stakeholder community, interspecialty collaboration, which we've seen in a couple of the models, but I think could be more expanded, is something where there's an opportunity beyond just primary care, one specialty. I'm going to give an example.
Thanks, Jen. All right, we're cresting the hill. The last one relates to the stakeholders themselves on potential insights that we can provide to them as they think about developing their proposals. Yep. Someone wanted to make a comment? So that was the last one. So what kind of advice that we haven't already shared and we should incorporate in the report for the secretary that we'd want to flash to the stakeholder community on, hey, if you're thinking about a proposal that we haven't already touched on, is there anything else that we'd want to add for their consumption?
I'll offer this quickly. You know, we have 3 criteria that we've promoted to be the most important. And care coordination is number 7. And we might want to say something, I don't know if we want to change the ranking, but say that this is something we would regard as very important. Not that the other criteria aren't, but maybe we'd want to highlight that a bit.
Well, That's a big point. And I guess we have the committee on the line. Maybe Bruce, we can make that a more of a formal request. We don't have to say it's a high priority item, or we could, but we maybe want to talk offline about revising our descriptions of the 10 criteria and where they rank and how care coordination sort of falls out. Because one of the reasons we're having this team-based meeting is because of what we've observed over the models that have come in around some of the soft spots around care coordination. And so perhaps we need to revisit it. I guess my feeling is we probably do. So thank you for bringing that up. How do others feel about that?
You're welcome, Jeff.
I agree. Yeah, I think we've been at this for whatever you said, 5 or 6 years now, and it is a good time to relook at what we think is the high priority ones. I think there aren't more opportunities for physicians to participate, so I know it's been a priority. So that may not necessarily be as much a priority as it was when we started. So yeah, I think we should relook at all that.
Yeah, I agree.
Okay. Kavita, did you have your hand up? I wasn't sure.
Just Paul said it. I completely agree. And if anything, just given the refresh on thinking about APMs, it might not be bad to take a look and also align it to some of the priorities that we know, not just CMS, but kind of the payer space is interested in.
Mm-hmm. And I remember, Kavita, I think you were the architect, not in a vacuum, but you worked with the committee. I think you led the charge in developing the secretary's criteria, not developing them, but incorporating them into our process,
Right.
if I remember, because there were more than 10 and we ended up with 10. And so
yeah, Bruce gets, there's credit to go around, but yes, and that was when we didn't really know what we were getting into. So it'll definitely be more informed now.
For sure.
There's blame to go around too, so we'll share them both.
Stop. You guys. Okay, so as we wrap this up, I think this has been a great session. I think the panelist sessions have been also incredibly informative, and I would like to turn to our colleagues, our ASPE colleagues who have been following every word. Any input, any comments, Audrey, Steve, Nancy, that you've been made listening in that you think we should do before we wrap up today's session, or any questions you have of us that need clarification before we wrap?
So this is Audrey. I don't have any questions.
Thank you, Audrey.
Yeah, from my perspective, I think, we'll all have the challenge now, like we did with telehealth, of taking the incredible amount of valuable information we got today and do a report like we did on telehealth, maybe a little quicker, that really it boils it down to what's most useful for the secretary and for the Innovation Center.
Great. Thank you. Thank you for that. And I just want to thank everyone for participating today. These sessions obviously were originally designed to be in person. That was the way the committee functioned, and I missed that. And hopefully we'll have the opportunity to get back together soon, maybe in the September meeting. Still not clear if that's going to be virtual or not. But just want to thank publicly my colleagues on the committee and also the public for leaning in and providing your attention. And I know we'll get comments after the meeting. We've explored many facets of care coordination today, and it's how it relates to alternative payment models. As I said this morning, we will continue to gather information on this topic through a request for input. We're posting that on the ASPE PTAC website, a link that will be circulated through the PTAC listserv. So watch out for that. Our next public meeting, as I said, is in September. We're excited for the next theme-based topic, which is optimizing equity and social determinants of health. in the context of alternative payment models. We touched on some of that today. I want to thank you all for taking time out of your day and your busy schedules, those leaning in and listening in, also those that participated. Very grateful for our panelists as well. Please take care and be well. And the meeting is adjourned. Thank you.
Produced by the U.S. Department of Health and Human Services.